I do want to just note for anyone watching this recorded version that this is not eligible for CME1 credits if you are watching the recorded version, but there should be a link in the chat to a different option if you would like to claim credits there. So with that, I'm going to go ahead and introduce Dr. Gupta. She is a pediatric dermatologist at Seattle Children's. She's triple board certified in pediatrics, dermatology, and pediatric dermatology. She completed her medical degree at the University of Washington School of Medicine, and all of residency and fellowship trainings were completed at the University of California, San Francisco. She sits on the executive board for the American Academy of Dermatology section for dermatology and is the chair of the Global Health and Outreach Committee of the Society of Pediatric Dermatology. So very well qualified to speak to us today on this topic. With that, Dr. Gupta, I'll turn it over to you.
Thank you, Erin, for that great introduction, and thank you everyone for spending your lunch hour with me. Today we're going to talk about atopic dermatitis. I want this to be as interactive as possible. I want this talk to really answer your questions that you have, and without further ado, we'll kind of go ahead and start. So please put your questions in the chat. I'll pause in the middle and to answer any questions as well, and at the end. All right, so just a couple of slides. So this is an accredited talk. You can get 1 credit of CME credit, which is wonderful. These are just the accreditation slides regarding all of that. I have no disclosures, no relevant financial interests or disclosures related to this talk. And this talk was formed with the Peer Review Institute. They also do not have any relevant financial relationships related to this talk. We will be discussing some off-label uses of medications in this talk, so just to let you know that. And then a couple housekeeping notes that Erin also mentioned. There is this post-test evaluation that you should complete if you'd like to have CME credit. So identifying and assessing the severity of atopic dermatitis in children, we will kind of talk about atopic dermatitis, introduction to atopic dermatitis, how to diagnose and assess the severity, as well as discuss, do age and race really make a difference in how we diagnose it in severity, and then what can we do to manage and treat atopic dermatitis. So our goals for today are really to be really comfortable with the clinical presentation of atopic dermatitis and learn how to evaluate the disease in individuals with lighter skin types as well as darker skin tones, and by age as well. Learn kind of how we can collaborate with our specialists, when we should refer, and how to transition kind of children to adult care. We'll talk about the treatment of atopic dermatitis, what we do for mild disease, moderate disease, more severe disease, and overview some of the targeted treatments that are available. And then we'll kind of really develop a kind of an algorithm and a treatment plan to manage patients with atopic dermatitis. So atopic dermatitis. When we think about atopic dermatitis, it's really a kind of clinical phenotype. Atopic dermatitis oftentimes presents as kind of ill-defined erythematous papules and plaques on the body, and it's really common. All of us have seen this in our practice. The prevalence is 15 to 20% in children and 1 to 3% in adults. It's really a disease that presents earlier in our lives. Most kids have atopic dermatitis diagnosed before age 5. About 80% of cases are diagnosed then. And with the 15 to 20% of children that have atopic dermatitis, about 1/3 of them actually have moderate to severe disease. So those are the ones that we want to think about. What can we do to optimize their treatment in the primary care setting, but when do we also refer? The symptoms of atopic dermatitis can be very profound. They have significant impact on quality of life, on sleep, not only for the patient, but also for families. And there's a lot of associated atopic comorbidities. Patients that have atopic dermatitis can also have other atopic diseases such as allergic rhinitis, conjunctivitis, asthma, eosinophilic esophagitis, or gastrointestinal disorders. And that's really important to know about, as well as some of the targeted treatments that we might be talking about later on today are actually FDA approved for some of these indications as well, so that they can have a real impact on the quality of life of our patients with atopic diseases. And thing that can be frustrating about atopic dermatitis is that it's a chronic condition. There's no cure for it, but what we can do is equip families and kind of healthcare providers with the tools to educate our patients of things that can help to minimize the impact of atopic dermatitis on their life, to control symptoms such as pruritus, inflammation, things they can do for maintenance and preventative measures, and things they should do when things start to flare for treatment. So as we kind of talked about briefly, the symptoms of atopic dermatitis can really be profound. They don't only impact quality of life and sleep, but patients that have atopic dermatitis can have much higher rates of depression, anxiety, and other kind of sleep disturbances and other comorbidities related to ATP. And we really should be thinking about the whole patient here, not only the severity of their atopic dermatitis clinically, but also the other effects that it's having on their quality of life and these other associated comorbidities, because those all go into when do we start something, when do we escalate therapy, and when should we be considering more systemic treatments for them. So the diagnostic features of atopic dermatitis. So the essential features, ones that are present in kind of all cases, is the typical kind of morphology and age-specific patterns of eczema, of atopic dermatitis. We see that it's kind of an ill-defined, it presents kind of as an ill-defined kind of erythematous papules and plaques. It most commonly presents on the flexural areas like the antecubital fossa and popliteal fossa. But what we see is that in younger age kids, like the less than two age group, infants and toddlers, atopic dermatitis tends to come up in areas of friction and trauma. So we see a lot more facial and scalp atopic dermatitis, because those are areas where they may have seborrheic dermatitis and Pityrosporum ovale and malassezia that are driving those processes. So the atopic dermatitis likes to kind of follow the path of least resistance. If there's already some trauma to the skin, it will hone in on those areas. And as infants kind of start to get on those forearms or start to crawl, we'll see atopic dermatitis in those younger age groups actually be more extensor surfaces rather than flexural. All patients with atopic dermatitis have pruritus, and that is a significant effect on quality of life and sleep. And we'll see this kind of chronic, relapsing, remittent kind of history. So it kind of comes and goes. The things that can flare it can be multifactorial. So patients with atopic dermatitis can be flared by environmental allergens. Their skin barrier is defective, and so things can get into the skin that then lead to inflammation, such as environmental allergens, infections. Definitely heat and cold can also trigger these atopic dermatitis flares. Those are things that we see in every patient with atopic dermatitis. And this is kind of some pictorial representations of that morphology that we see with atopic dermatitis. And we see from the patient on the left, kind of on this is a younger child in the less than two group. And we can see that the face and the neck have a lot of these kind of ill-defined, kind of erythematous, kind of xerotic patches, and thin kind of xerotic papules. But then there's also some predominance on the dorsal hand, so like more on an extensor surface, and then kind of the torso having these kind of ill-defined erythematous papules, a lot of excoriations that you're seeing as well, and then also involvement on the extensor surfaces of the knees. And so when we say ill-defined, we can't really see exactly where it starts and stops, these atopic areas. They're not really sharp or crisp, and that's to mirror it to an inflammatory disease like psoriasis, where the plaques and papules are actually really well defined and well demarcated. We could take a pencil and pen and kind of draw that border out, but that's not the case with atopic dermatitis. The middle picture, we're seeing an individual with darker skin. We're seeing on the popliteal fossa, the flexural areas, these kind of ill-defined, lichenified, hyperpigmented, and slightly erythematous plaques. And by lichenification, we're seeing those skin tension lines. So if you look at your own palms or your own forearms, you can see that we all have these tiny little skin tension lines. And when an area of the skin is itched, rubbed a lot, then the skin gets thickened and those skin tension lines become more prominent, which is kind of what we're seeing on the back of these knees on the popliteal fossa. And then here we're seeing another child on the right with kind of palmar involvement, and you're seeing these ill-defined kind of xerotic excoriated plaques on the palms. As well as in the antecubital fossa and scattered excoriation. So these are like the classic looks of atopic dermatitis and how it would present clinically. And then in an individual with maybe lighter skin background, we can see that the erythema is much easier to identify here. We're seeing some classic areas of atopic dermatitis on the popliteal fossa here. We're seeing on the right some excoriated plaques and lichenification of these erythematous plaques, and some almost serous kind of honey-colored crusting as well for some of those erosions. And atopic dermatitis tends to be more of a kind of a dry condition, but we definitely see in the younger age group, the infants that have a lot more facial predominance, that it can be very oozy and weepy and sometimes be more crusted. And sometimes we'll see that honey-colored crust too when there's signs of infection uh, or impetigo, that bacteria might be getting into these areas. In darker skinned individuals, sometimes atopic dermatitis can be missed because that erythema may not be as prominent, and there may be some other morphologic features that are prominent in the skin. And so here we're seeing an individual with darker skin tone, that the erythema, you don't see it as prominently as you would in a lighter skinned individual, but patients with darker skin tones also can have more lichenification. So the picture on the far right, you're seeing these really hyperpigmented, lichenified, kind of really thick plaques that are involving the anterior shins, the dorsal feet, the dorsal parts of the first digits, the knees. And then what's kind of interesting is that the creases, like on the superior part of the foot, are actually spared. And that's probably because those creases are areas that retain moisture because they're occluded. And so we're seeing atopic dermatitis spare there. And that's actually why we oftentimes don't see atopic dermatitis in the diaper area either, because that environment is kind of a moist environment. And so because of the occlusion with the diaper. And so we don't see atopic dermatitis oftentimes spares the diaper area. The other area that it also spares is the nasal tip, and that's because the nasal tip has a lot of sebaceous glands, a lot of oil glands, which kind of hydrate the skin. And so those are some areas that we actually see atopic dermatitis sparing. Other morphologies that we see in individuals with darker skin tones are we see the picture kind of on the bottom left. You're seeing kind of a cluster of these little fine follicularly based papules. And so there can be much more follicular or papular morphology. And then the photo above it, you're almost seeing these more rounded, more well demarcated plaques, and that morphology we call nummular, and nummular means coin shaped, and that's another morphology that we can sometimes see in darker skinned individuals. The nummular morphology is also something that you'll see more in infants. They have these kind of thicker coin shaped plaques that can be more oozy and weepy, and that morphology, because of the thickness of the lesions, can be harder to treat and sometimes require a bump in the topical corticosteroid strength. And then we're seeing just more lichenification in general in a lot of the pictures that are shown here. So here we're seeing, we alluded to some of these things earlier, but atopic dermatitis actually really does change by age as far as its distribution. And the mainstay and the reason that it does that is because it likes to follow the path of least resistance. It likes to follow where there's maybe already more trauma to the skin or more friction to the skin. So in infants, kind of in the first couple years of life, we're really seeing a lot more facial predominance around the cheeks. That's probably exacerbated by saliva. Saliva has a lot of irritants to the skin, and so it's probably irritating the skin, and so the atopic dermatitis will come more to that area. The scalp and the ears, and that's because there's probably an overproduction of yeast causing seborrheic dermatitis, and so atopic dermatitis is kind of honing in on those areas. And then the extensor surfaces, as we talked about, they start to get on their forearms and start to crawl. In childhood, we're seeing more of that classic look, the flexural areas being more prominent, but still some kind of facial areas. Eyelids tend to be a really specific area that sometimes can be present for atopic dermatitis. And then as children get older to teenagers and even into adulthood, we're seeing maybe more hand atopic dermatitis, flexural involvement, sometimes dorsal feet, wrists, and sometimes nipple and eyelid dermatitis also tend to be more prominent. And that might be related to some of the products that they might be using or the activities that they may be more a part of, hobbies. We know that patients with atopic dermatitis tend to be, because their skin barrier is more open, it might be more prone to reacting to irritants, allergens in their environment, and they're much more at risk for allergic contact dermatitis as well. And so that might be why those areas may be more prominent as we get into teenage and adulthood. So in addition to those essential features that we kind of talked about, we also know that atopic dermatitis is something that really does onset early on. A lot of cases might show onset before 1 or before 5 years of age. It's more unusual to have new diagnosis atopic dermatitis as an adult. We also see those individuals that have atopic dermatitis have a strong family history of atopy in general. So not only in their families, but sometimes also in themselves too. They may be more prone to atopic diseases. They might have higher kind of IgE reactivity, and they also have xerosis, just dryness of the skin. And the reason for that is that many patients with atopic dermatitis have a mutation in filaggrin, kind of going back to maybe what we learned in medical school, but filaggrin is one of those essential building blocks to our skin barrier. And when it's mutated, the skin can't hold on to moisture very well, can't hold on to water. And so that water evaporates. It makes the skin much drier. And things that you can see in patients that have filaggrin mutations, if we all look at our palms right now, we can see that there's actually lots of lines throughout our palms. Patients that have filaggrin mutations oftentimes have hyperlinear palms, meaning that those lines that we see might be much more in number and more prominent. And with water constantly evaporating out of the skin gets more dry. It also allows things to come into the skin that then activate an inflammatory cascade. This is just showing that, when one parent has kind of atopic disease, then the increase of a child developing atopic dermatitis is 1.5-fold. But if both parents have some type of atopic disease, then that risk goes up to 3 to 5-fold. And about 70% of patients with atopic dermatitis do have families that have some type of atopic disease. And we find that as we're talking to patients and families that this is pretty common. And then atopic dermatitis is one of the first kind of manifestations of atopy in an individual. And there's some thoughts that the skin having defect in its barrier, being more prone to allergens, may make patients more at risk for developing other types of ATP down the road. So allergic rhinitis, asthma, food allergies. There has been some studies about looking at food allergies and atopic dermatitis, and there's a famous study, the LEAP study, looking at peanut and introduction of other high allergen foods earlier on in patients that had atopic dermatitis that were maybe more, even mild, but definitely moderate to severe early on, just to uh, prevent the development of these high risk food allergies. So introducing like peanuts and smaller kind of aliquots earlier on was actually thought to be more preventative in developing a peanut allergy later on in patients that had atopic dermatitis. And then finally, besides the kind of things that essential features we can see and some important features, we also might see in patients that have atopic dermatitis, they might have other cutaneous manifestations like the hyperlinear palms that we talked about, keratosis pilaris. So if we feel, the backside of our arms or our cheeks, some of us might feel some bumps on those areas, and that's keratosis pilaris, which is a kind of a hyperkeratosis. It's follicular based, where you get these flesh colored papules, and it's a form of kind of dry skin. We also might see kind of ichthyosis vulgaris, which is ichthyosis just means like a fish-like scale. So we might see this kind of fish-like scale on our anterior shins, which may be a manifestation of dryness as well. And so we can see all of those other things with patients that have atopic dermatitis as well. So we kind of just talked about the morphology of atopic dermatitis, how it might present in patients by age, and how it may look different in different skin colors and skin types. And then now we're going to talk about kind of how do we assess the severity of atopic dermatitis. And so mild disease, so the severity really is based on the appearance and the look of the atopic dermatitis. And so in mild disease, we might see more kind of pink, kind of mildly erythematous, kind of superficial thin papules and plaques. We may see like less of the erythema, but maybe more kind of hypopigmentation or hyperpigmentation, which is maybe more the residual of the active inflammation that's resolved. And then we don't see as much like lichenified skin or thickened areas of skin. We'll see less crusting and oozing of the skin. So here we're seeing on the picture on the right, we see some on the antecubital fossa, we can see some actually ill-defined hypopigmented macules and patches, and some superficial, mildly erythematous kind of excoriated papules in these locations, and then also some subtle kind of erythematous papules on the anterior abdomen as well. So that's more mild disease, and sometimes an individual could have just these like barely perceptible, subtle pink, thin, superficial papules, but they could be fairly diffuse. So they could involve a large body surface area, but they're still very, very superficial. And so just because they have a lot of body surface area involvement doesn't mean that we always would just categorize them as severe. The phenotype of mild has to do with kind of the appearance of the individual lesions, because that tells us how responsive it may be to just topical treatments, or if they need some to advance treatment to something systemic. When we talk about moderate disease, here we're talking about more kind of well kind of seen papules and plaques. There may be some kind of thickness. The plaques themselves may show some oozing, some crusting. There might be some like dull kind of erythema even to the background skin, and the individual plaques will be more, and papules would be more kind of erythematous. And here we're seeing different variations of that as well. And then for more severe disease, here we're seeing much more thickened, like lichenified papules and plaques. You might also see a lot more erosions and ulcerations of the skin, a lot more excoriations, um, and a lot more widespread nature of the rash, and a deeper, kind of brighter red and erythema to the skin. Um, On the picture on the upper right, you're seeing that there are these really lichenified, kind of eroded plaques on the extensor surfaces of the knees and the dorsal feet. But the areas on the shins are pretty spared, and so sometimes it doesn't always have to be as widespread, but just the nature of having these really, really thickened areas can actually confer severity of the disease as well, because they can be really difficult to treat. So the assessment, like assessing the severity of atopic dermatitis, has to kind of do with the morphologic characteristics of the individual lesions of atopic dermatitis. Um, that plus, the extent of disease is helpful, but sometimes just even having really severe kind of lichenified excoriated plaques can push patients into more severe disease without having it be as widespread. There are some tools, and I'm just going to briefly touch on those. And the reason I'm touching on these is one, it's helpful to put in our documentation. In this day and age, it's really hard to even get things covered by insurance companies, even topical medications. And so it's important to sometimes be aware of some of these tools. It also can help us assess, what the patient's perspective may be and how atopic dermatitis may be affecting their quality of life. So one such validated tool is the investigator global assessment. And this really has to do with like the morphology of how severe the individual lesions are. 0 being clear, it's a 0 to 4 scale, 0 being clear. 2 is kind of mild, where we saw some pictures of that, like having areas that are slightly kind of erythematous, but not a lot of oozing or crusting or lichenification, whereas severe is really that marked erythema, lichenification, excoriated, indurated kind of disease. And so this is something that I put in my notes based on what I see on the patient, and that can be really helpful in getting certain medications covered as you're kind of putting a validated score on a patient's severity. Other tools that are used more in clinical trials are the Eczema Assessment Severity Index, the EASY, and then the SCORAD, the Scoring Atopic Dermatitis scores, and these are much more involved scoring tools that, based on the number that you get out and add up, can break down disease into mild, moderate, severe. Those are not as used in just everyday clinical assessment, but I do find the IGA being something that doing a full body exam and looking at the patient's skin, you can give a score to. And then there's some patient reported outcomes. These are things that maybe you could incorporate into your EPIC or your medical record that patients can sometimes even do just to report in a validated way their quality of life and how much some of the symptoms such as pruritus may be affecting them. These are just other tools that can be helpful in trying to get medications covered as well. And so practically, I think that we really should be looking at body surface area. We should be looking at severity and extent of disease, and really kind of describing the symptoms that patients have and the effect that that has on their quality of life. And what we do know is that atopic dermatitis does have significant effect on quality of life for our patients. So here, this is kind of a busy slide, but you can see that the orange bars highlight mild disease, the blue bars moderate disease, and the green bars more severe disease. And and what we see is that as far as atopic dermatitis limiting our lifestyle, avoiding social interactions, and just our effect on activity, daily activity for patients that have atopic dermatitis, we see that patients that have more moderate to severe disease, those blue and green bars, that they are more skewed to the left side of these graphs, which say that they're more affected by their atopic dermatitis as far as their lifestyle, what they do, how they interact with people. And so it does have significant effect on them. And sleep is one place that there is significant impact for atopic dermatitis, not only on the patient, but also on families as well. We see that the sleep not only impairs quality of life, but also patients can have much more behavioral problems, um, associations with ADHD, associations with kind of poor growth, and that affects caregivers as well and increases their anxiety and depression. And we see that as our patients transition into adulthood, that they also have, maybe a negative effect on their mental health, social functioning, activities of daily living. And so this is something, a reason to kind of treat atopic dermatitis early, and refer, early for more moderate to severe disease to help patients get better treatment of their atopic dermatitis. And this is just showing, how much effect atopic dermatitis has on families. This was a study looking at infants and preschoolers, and the mean dermatitis family impact score, so greater than 10, represents kind of moderate to high alteration in quality of life. And almost 50% of patients with mild disease actually reported moderate to high alteration in quality of life, and almost 80% of patients that has severe atopic dermatitis. So it's really a disease not only of our individual patients, but has significant effect on our families as well. And then in addition to all the effects that we just talked about with sleep, and the impairment of sleep, largely due to pruritus for atopic dermatitis patients, we also see that patients with atopic dermatitis have a much higher rate of allergic contact dermatitis. So being much more prone to kind of preservatives, metals, perfumes, dyes that are in our everyday products. Uh, that sometimes aggravates and keeps kind of areas of atopic dermatitis refractory for some patients. And it can be really difficult to diagnose because patients can have their atopic dermatitis underlying, and the allergic contact dermatitis can look very similar. But I urge everyone to think about allergic contact dermatitis in our patients because it definitely is underappreciated, it's underdiagnosed. Definitely, if you have areas that are not clearing up, that are more refractory, where I would ask about other things that they may be doing, other products they may be using. One example of this is in a patient that I had that was 10 years of age, had pretty moderate to severe atopic dermatitis, but really localized areas around the perianal area. And so kind of different morphologies than I would think for that age group, and also locations where I may not always think of atopic dermatitis being like in the perianal area. And so upon further questioning, it was revealed that they're actually using baby wipes to wipe their face after meals, and using baby wipes to wipe themselves after going to the bathroom. And so the wipes themselves had a common preservative that was causing an allergic contact dermatitis. And so sometimes doing a little digging, you might uncover things that you wouldn't be expecting them to use. And that might be what's causing those areas to be refractory. Because of that impaired barrier for atopic dermatitis, we see a much higher rate of infections, not only viral infections like HSV and molluscum, but fungal infections like tinea, and also bacteria like group A strep and Staphylococcus aureus. We see that if we swab normal skin on patients that have atopic dermatitis, they oftentimes are colonized with bacteria that's just waiting for open areas of skin to then infect. So those infections can cause acute flares, an acute increase in pruritus. So if you do have a patient that's flaring or their atopic dermatitis all of a sudden is much more pruritic, think about infections, evaluate for infections. And then there can be a risk of kind of other immune dysfunction and other immune, like even autoimmune diseases that can be more prominent in patients with atopic dermatitis. We see higher rates of autoimmune diseases such as alopecia areata, vitiligo, celiac disease. So those are also things to kind of think about. I've had some patients with alopecia areata that when we've treated their atopic dermatitis with systemic medications, that sometimes their alopecia areata has also gotten better. And that might be related to the fact that these are autoimmune that are altering or activating the immune system, such as inflammation from the atopic dermatitis, may also be aggravating these conditions as well. So sometimes treatment of the underlying cause that might be aggravating or activating the immune system can also help the autoimmune diseases. So not only looking at the severity of disease. So children that have maybe more mild or have more moderate to severe atopic dermatitis, those you may be referring who are not doing well with treatment, but also taking into account the whole quality of life, the impact it's having on sleep, on their schooling, on their activities, taking that all into account, and thinking about all of those pieces when you're thinking about when should we step up therapy and when should we refer. If you're thinking about referring, or if patients really have more of that moderate to severe atopic dermatitis and or significant effect on their quality of life, referring early is really helpful so that we can think about other ways to kind of ramp up treatment. So this is just a case about kind of looking at all the pieces that we talked about. So this is a 4-year-old male who has a history of eczema since infancy, significant itch causing sleep disturbance every night. They're using adequate amounts of mid-potency topical steroids and topical calcineurin inhibitors. He is positive for by patch testing for tocopherol, which is kind of a preservative that's seen in some emollients and over-the-counter products. And he also has kind of other evidences of Atopic. He has allergic rhinitis, a frequent nocturnal cough. He also has evidence of kind of xerosis and associated features that we can see with atopic dermatitis, such as ichthyosis vulgaris. And here we're kind of seeing these lichenified kind of erythematous plaques on the flexural areas and on the volar wrists, as well as on the lower extremities as well. And so kind of putting all these pieces together, based on just the appearance of his lesions, they're slightly lichenified, they're a little bit thickened. I put him, you see erosions, excoriations. So I put him in more of the moderate kind of atopic dermatitis category. And then things that kind of bring me over to that category as well is that he's, having interference in his sleep. He has other comorbidities of Atopic. And so I would put him more in the moderate category and thinking about how we can maximize his topical treatments and, having maybe a discussion in the future if that's not helpful of when to advance to more systemic treatments, which we'll talk about in the next section. So I will just pause there for one moment and see if there's any kind of questions about kind of diagnosis, treatment. I'm looking at the chat here too, and some great questions there. So one question is there any risk factors or predictors that can help distinguish pediatric eczema that will more likely lead to adult eczema? And kind of the short answer is not specifically, but definitely kids that have more moderate to severe atopic dermatitis earlier on, they may be ones that are more prone to still having features of atopic dermatitis in their adulthood. Would be one kind of more severe that it is earlier on, might have a poorer outcome when they're adults. And then have there been any links between food triggers and eczema flares? So yeah, definitely. I think atopic dermatitis, about 30% may have kind of an association with food allergies, but not all atopic dermatitis is associated with a food trigger. But if patients do have a food allergy, it could trigger their atopic dermatitis. patients that should undergo allergy testing are ones that have kind of moderate to severe atopic dermatitis earlier on and who may not be responding to adequate treatment and may have a food that they have that's constantly triggering their atopic dermatitis and it's reproducible and consistent. So those might be ones that you might think about treating. And then, see. And then we'll talk briefly about TCIs coming up. And then talking about creams and ointments in infancy to help prevent atopic dermatitis. Is this something we should be recommending to all or just with family history? And so I think the question is more about use of emollients. And there's been some controversy about the use of emollients and if it can actually prevent atopic dermatitis or not in patients that might have like a stronger family history. And so I think that there is some evidence to say like earlier treatment of a disrupted barrier could be helpful. Maybe it would decrease the amount of allergens that would come into the skin and cause the inflammatory response. But then there's other studies that show that maybe emollients don't make that much difference in kind of preventing atopic dermatitis. So I think that there's both sides. But I think what we do know is that repairing the skin barrier in patients that might have a defective barrier can decrease maybe the frequency of their flares just because it would add a piece of not allowing infections or allergens to get inside to cause that inflammatory response. Any other questions that anyone wants to unmute themselves and throw out before we head to the next section?
Dr. Gupta, while people think about if they have any more questions, I don't know if you can see, but you have a Microsoft Auto update sitting in front of your slides. So just heads up, your computer wants to reset itself in about 36 minutes. We should be wrapped up by then, but don't know if you can minimize that. And
is that better?
Yes, perfect. Thank you.
Okay, I couldn't see that. Thank you so much. Okay. Well, then I'll just transition now to treatment and management of atopic dermatitis. So, when do we think about kind of targeted treatments and how do we escalate our algorithms? So what's our main goal of atopic dermatitis? So one is to stop the inflammation, and that really is repairing that skin barrier, which is through emollients, addressing the itch. So the itch is oftentimes driven by inflammation. Our main ways to address that inflammation is via topical corticosteroids, topical steroid-sparing agents such as calcineurin inhibitors, or we'll talk about phosphodiesterase 4 and JAK inhibitors as well. And maybe we need to sometimes escalate that treatment from beyond just topicals to systemic treatments that will address the itching if we can't do it with just topicals. And then prevent kind of recurrence and triggers. So for some patients, those triggers can be infection. And so if we want to prevent infection, we might be thinking about not only repairing the barrier, but adding preventative strategies such as like dilute bleach baths or treating the triggers. Some patients may be triggered by certain allergens or environmental allergens. So thinking about how to avoid those triggers. And then we really want to treat the atopic dermatitis in a way that's safe, but also that's sustainable. So one example of this is that I have a lot of teenage patients and, they don't like to use things that are really greasy on the skin. And so we know that ointments tend to seal in moisture better. They tend to absorb into the skin better. They deliver medications better, but they're really greasy and they can leave oil spots on clothing and so if someone's not going to use a treatment, then it's not something that's going to be sustainable. And so really kind of getting to know your patients and what they're willing to use, because that's always going to be better than using nothing. So that's part of that shared decision making. That's kind of the goals that I think about when I think about every patient that comes through. And this is kind of just highlighting how complex atopic dermatitis is as far as its kind of inflammatory process. And so it's highlighting kind of type 2 inflammation. And here we have at the center an impaired barrier, those keratinocytes. I think about the skin as like a brick wall. We have the bricks, the keratinocytes, and we have the motor between them kind of holding them all together. And in atopic dermatitis, that motor is just not there. It's kind of defective. And so water is flowing out, making the skin really dry. But then allergens, bacteria, viruses are getting in and causing that inflammatory cascade. And that's what we're seeing here, that inflammatory cascade then activates, the mast, our kind of type 2 lymphocytes, our Th2 lymphocytes. And then that's leading to an increase in interleukins and Th17 and aiding that kind of pruritus. And then the pruritus is then causing more disruption of the skin barrier. So it's just this loop that we have to kind of address, repairing the skin barrier, addressing the pruritus, decreasing any kind of triggers or treating triggers such as infection, and working all together and doing all of those things to really stop the inflammation of atopic dermatitis. And now, in the last, few years, we have a lot more options to treat patients with atopic dermatitis with, and targeted treatments that look specifically at some of these inflammatory drivers. We have Dupixent, so dupilumab, which is an injectable that targets IL-4. We have IL-13 blockers, IL-5 blockers, and then we have some more broader immunosuppressives such as JAK inhibitors that are FDA approved for our patients, our pediatric patients, which is really, exciting. So what are the basics? So the basics for every patient with atopic dermatitis is one, moisturize. Add that moisture back to the skin. And moisturizers come in lotions, creams, and ointments. Ointments are going to be the ones that are thicker, the greasiest, seal in that moisture, and probably be the most effective at doing that. Creams are ones that come in a jar. They sometimes can sting on a lot of open skin. They're thicker than lotions that come in a pump bottle. There's less alcohol in them to make them thinner, but they may not be as hydrating as an ointment. And then lotions are things that, they'll absorb into the skin better, but you might have to apply it more often to be able to hydrate the skin just as well as an ointment. Um, uh, as far as showering and baths, I oftentimes tell patients to kind of limit the length of their showers, 5-10 minutes, not hot showers, warm showers. And as far as soap, using things that are mild, and you don't need to put the soap everywhere. It does strip the skin of its natural oils. And so you want to maybe limit it to areas that are really more dirty or more need it more, and using things that are perfume and dye free, as those can be irritating. Dilute bleach baths is also something that's really helpful. Bleach has sodium hypochlorite, has anti-inflammatory properties as well as antimicrobial properties, and so sometimes can be used in conjunction with all of these other things as a preventative strategy, and then avoiding triggers when there is one. So taking those basic managements, and then in mild disease, adding kind of prescription topical treatments. So our topical corticosteroids are the mainstay of treatment. You can use this at all severities of atopic dermatitis, but patients with mild disease might just have a kind of an intermittent course with topical treatments. Besides corticosteroids, there's calcineurin inhibitors, which are great to use on thin-skinned areas for chronic disease. So I like to use it on the face, the eyelids. I also sometimes use it as if we need a break from steroid in kind of more persistent areas. And then there's also topical JAK inhibitors and phosphodiesterase 4 inhibitors like Eucrisa or crisaborole, which can be used when steroids may not be indicated. And so this is what maybe mild disease would look like. You're doing your maintenance treatments of dry skin care, considering dilute bleach baths, and then addressing the inflammation with oftentimes topical corticosteroids when needed. And just a kind of a highlight on which topical corticosteroids I reach for. So Steroids come in classes 1 to 7, 7 being the least potent, and 1 being the most potent. So when I have areas of thin skin, like the face, I might reach for something that's in the lower potency group, like a 6 or 7. So those are things like desonide or hydrocortisone. When I have maybe eczema on a moderate kind of thickness area, like arms, legs, extremities, body, I might reach for like a class 4 steroid, like triamcinolone. And then if I have areas that are refractory to treatment or thicker skinned areas, like maybe acral areas, palm soles, I might go to more potent topical steroids, which is things like mometasone, betamethasone, and even clobetasol if things are refractory. Topical corticosteroids are really safe. There's sometimes just a lot of phobia around the idea of steroids, but when you use them kind of intermittently, I usually say twice a day for 2 weeks with at least a 1 week break between courses, then we can really avoid adverse effects like skin thinning or telangiectasias, and they can be really safe to use. But sometimes we do have to reach for something that does not have steroid in it, and though those are like our topical calcineurin inhibitors. Pimecrolimus and tacrolimus are both FDA approved for atopic dermatitis in 2 years or greater, and they're great for chronic thin-skinned areas. One thing about them is that they do carry a black box warning that which really is more true for the oral medication, not the topical. I haven't seen any cases of this with the topical calcineurin inhibitor use, but a warning that it may be associated with non-melanoma skin cancer or lymphoma. The vehicle that the medication is in can cause some stinging. So that's one thing that I do tell families about. Putting it in the fridge or putting it on cold can sometimes decrease that stinging. And then other topical treatments, such as crisaborole, it's also a non-steroidal option. It can also sting, and I feel like patients report that a little bit more with crisaborole than with calcineurin inhibitors. So again, putting it in the fridge or putting it on cold. And then topical JAK inhibitors are also FDA approved for 12 and older as a topical option, a non-steroidal option, as well. So in some patients, using topical steroids appropriately and an adequate amount, um, it may still not control their disease. And so we might need to step up. And when we step up, based on the severity of their disease or kind of the extent or quality of life, um, things that we may step up to are things like phototherapy. Narrowband ultraviolet light therapy can suppress the immune system in the skin and cause that decreased inflammation. There's now targeted treatments like biologics, like dupilumab and JAK inhibitors. And then we also have kind of oral systemic immune modulators that are not as targeted, that can also be used. And then wet wraps as well. When we think about escalating systemic therapy, we just want to make sure that there's something we're not missing, making sure that there's no infection that's driving things, no allergic contact dermatitis that might be driving things, and really put the patient at the forefront of the discussion and see how much is this overall impacting their quality of life, what other comorbidities they have, before we make that idea of advancing therapy. And so as we evolve this algorithm, in addition to using the topical corticosteroids, we might then go to the next step, and referral to a specialist is part of that next step, as well as incorporating these other therapies. And one plug about wet wraps. I do these with wet pajamas, cotton pajamas. I tell patients to take a bath or shower at night, pat dry, put on your medications to all affected areas of atopic dermatitis, a thick emollient on top of that, one pair of damp pajamas on top of that, and a dry pair of pajamas on top of that, and try to sleep in that. It's kind of making a tropical, humid environment for the skin to allow the medication to drive better into the skin and also protect the skin, make a barrier so that you can't kind of itch and impair that barrier of skin. So it has kind of dual purposes. So we kind of talked about the whole treatment. These are some of those non kind of um, uh, off-label kind of uses of overall broad immunosuppressants that we used to have. But now just to kind of highlight some of the things that we have now. So dupilumab is probably the best known and most data that we have for a biologic or targeted treatment. It's an injectable medicine that is actually approved for atopic dermatitis down to 6 months of age, but it's also now FDA approved for eosinophilic esophagitis, moderate to severe asthma, and prurigo nodularis. So can help with comorbidities for our patients. It is injectable. The studies that have been done have really shown that it has been effective in achieving 75% clearance in patients with atopic dermatitis. It's better than placebo, and I've definitely seen that in my patients as well. And it's pretty safe. Most common reactions we see are injection site reactions, conjunctivitis, dry eyes. It can reactivate oral herpes, so sometimes knowing if there's a history of that is good. But overall, its effect can be sustained, and we also see it in the younger age group that it's effective and safe for them as well. Um, and then it is injectable, so that's one thing to talk to families about and provide some use of distraction or other techniques or other like vibration devices near the injection site that can help them with being able to apply these injections at home, because that is one of the barriers to the medication. There's other anti-IL-13 antibodies that are now FDA approved in adolescents. Again, injectable has been shown to be effective, and there are further trials for younger kids. And then also other kind of IL-13 inhibitors that can be that are also FDA approved, again, showing that these are effective compared to placebo. It's great to have these options for patients, and anti-IL-31 medications too that are up and coming. So lots of targeted treatment options, which is really exciting. JAK inhibitors are also something that can be taken orally that are now FDA approved for 12 and up. Upadacitinib, and fairly well tolerated, but do require more lab monitoring. So something to think about. So I will kind of end there. And I hope that through this talk, you were able to kind of now feel more comfortable about diagnosing atopic dermatitis by age and by different skin tones, and think about that algorithm of mild, moderate to severe atopic dermatitis and how to, and when to think about referring, what other tools you can bring in for treatment of atopic dermatitis, and know a little bit about the targeted treatments that are out there for our patients. So I will take questions.
Thank you, Dr. Gupta. We had a couple in the chat I've been keeping my eye on.
Mhm.
As an FYI, your auto update was very persistent and came back about
Yes.
a minute after you dismissed it. So really wants you to know you're going to be kicked out soon. We
Okay.
have one question. Can you speak a little about treating infants with AD overlapping with, oh
Seborrheic
goodness.
dermatitis.
Yes,
Yeah.
what?
Yes. So essentially we treat the two very much the same. So with seborrheic dermatitis, you're getting kind of inflammation, erythema. And so we oftentimes do treat them very much the same with a topical corticosteroid. You may want to add something like a ketoconazole shampoo, because that would address some of the malassezia, or pittosporum ovale that might be also kind of driving the process. But it's sometimes really hard to tease out one or the other. But we would treat them very much the same with topical steroids and possibly some ketoconazole shampoo. And then, can you talk about the evidence of bleach baths? Can bleach be an irritant? So the studies with bleach, sodium hypochlorite, have been shown that it's actually an anti-inflammatory, as well as has antimicrobial properties. There's been some studies that have actually shown that it can help with like aging and things like that. And so this is really dilute bleach. So we're using about a quarter cup to a half a cup in a full bathtub of water, which is 40 gallons. Doing bleach baths and then sealing in the moisture from the bath afterwards, I haven't seen it being too irritating for patients. And I think the key of sealing that moisture too after bath can be really helpful. But it can be really helpful in patients in decreasing the inflammation and decreasing kind of infections. And then the use of topical calcineurin inhibitors for babies under 2. So the studies, the reason that's FDA approved for 2 and up is just because that's what the age that of cutoff for the studies. I have used it for patients that are younger than that, and find it to be kind of an effective and safe use of the medication. So I wouldn't hesitate using it in the right scenario for patients that are under 2. The main issue that I oftentimes run into is just getting it covered by insurance because of that FDA label. But there are kind of studies, case series in the literature that do show that it's safe and effective for less than 2. And then how do you decide between TCI use versus Eucrisa? And that I think the topical calcineurin inhibitors, so pimecrolimus and tacrolimus. Pimecrolimus is actually probably weaker than tacrolimus. Tacrolimus is more potent, and I find that the Eucrisa is probably strength-wise more related to the pimecrolimus, so it's probably less potent than tacrolimus. So one way that I would decide between the two is how potent of a topical corticosteroid do I need. Um, the other way that I would decide between the two is that Eucrisa is actually FDA approved for atopic dermatitis down to 3 months of age, whereas TCI use is 2 years of age. And so sometimes that makes a difference in which insurances will cover it. So that's another distinguishing point. And sometimes when you do need a nonsteroidal, using the one that's covered by the insurance plan or Medicaid is sometimes the one that you would go with.
Alrighty, I don't see any more questions in the chat, and we don't have anyone that raised their hand, and we are at 1:02. So want to thank everyone for attending today, and huge thanks to Dr. Gupta for the talk. Lots of praise for this in the chat today. So there was a link to the post-test and evaluation in the chat. I will send that out via email. Oh, and there's a QR code and also a link. So you'll get this lots of different ways. Please remember to fill that out so you can claim your CME credits. And we hope to see you again soon. Thank you all so much and have a great afternoon.
Thank you.